pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay.
Mr. Twitty, you're up first. Yes.
Where would you like us? Front and center.
On the firing line.
I don't actually have my correct oath, so if you'll stand. And are you up for election too?
No.
You're just standing in.
Well, you just told people to stand, so I stood.
Oh,
I just did-
we're taking the oath of office, but if you'd like to take it too, you know.
Oh, no, no.
Yeah.
So, do you solemnly swear to be the best board member that you can for the next 5 years? Or 4 years?
Yeah.
Just kidding.
I do.
Thank you. We appreciate your service and your dedication to the hospital district. In honor of Jim Lynch, he had a whole lot better things to say, better process. But thank you.
Okay. Next step, where the election of officers gonna be?
Dawn, would you consider, I know you've
It's
kind
been a
of,
long time.
you have been, but you are excellent at getting us through these in a timely fashion. You handle the public comment well when we have an irrational or a rational complaint. And so I would like to nominate Don Liddicoat as president chair for the coming year.
I would agree. I did take one note that he said in a timely fashion. I got that wrong too.
Okay, so, all in favor?
Aye.
Passes mostly unanimously. Okay.
Does that mean you didn't vote? Did you abstain?
No, I didn't abstain. I'll vote yea.
No, just making
Just for
sure,
the record.
for the record.
Okay. Secretary, who's our current secretary? Gerald is.
Me, no, sorry.
Hmm?
The me.
Oh, yeah.
Gerald, would you like to continue? Would we, Jen?
Sure.
Sure, we're saying sure.
Okay. So Gerald, we're nominating for secretary. For treasurer, John, would you like to be treasurer?
I'd be happy to.
Okay. So we've got
Second.
Gerald for secretary and John for treasurer. All those in favor?
Aye.
Passes unanimously. Okay.
Hi, Teresa.
Oh, look, you guys match.
Your
Okay,
numbers,
anyway.
your numbers are.
Or maybe I'm colorblind, I don't know. Public comment. Nothing from the public, all right. We're down to the consent agenda. We have the minutes from the regular meeting of April 8th. Should have been the May meeting, right?
It would have been the main meeting.
Hi, Marty.
Hi, Daryl. Hi,
So consent agenda should be on the May meeting, regular meeting. And we've got the July calendar that we passed around.
August.
Everybody had a chance to read the minutes?
Yes.
Okay,
I so move we accept the consent agenda.
Second.
moved and seconded to approve the consent agenda with the May regular meeting minutes. All those in favor?
Aye.
Okay, passes unanimously.
Yes, I'm sorry.
Okay, Ed, you're on. All right. This is your second big meeting to do this. We like to get the wheels going.
And I truncated all the numbers so that we move faster.
Okay, good.
Okay, first up, we have the Good evening, we have the patient count, field, I got a pointer now, so, for acute, 2021, it's 308 versus previous year at 311, so there's a difference of 3 patients. You go down to the clinics, 1541 last year, 1899 this year, so it's an increase of 358. Other outpatient services, 3854, and this year 5352, so it's an increase of.
What's an example of an outpatient service? What does that mean? What
That would be a CT scan. That would be a lab test. That would be physical therapy.
Ancillary services, radiology.
The real difference, of course, is the impact of COVID from last year.
Overall, year-to-date, had 80,902, an increase of 9,600 over the previous year. This is correct. Gross patient charges, for May, it was 4.3 million, an increase of 1.1 million over the previous May. 4.3 over last May at 3.4. Also, year-to-date, you see it's at 43.6 versus the 37.6 at the same time last year.
That green line that goes across 4521, that indicates what?
So this was the budgeted, targeted, budget. We're shooting for 47, give or take, through this month, but, you know, obviously, the COVID had a big effect of it, so. Really, I guess that's our target, but where we'd like to be at this time. As far as collections,
Wrong button.
get this. For collections, you see, last May versus this May was 2.3 million versus the 1.4, 26 for the year versus 25.
This is the amount collected, not accounts receivable.
Correct. And, so, and I can add some more color to that if you like, it's as far as what we have, accounts receivable, and you saw the detail and stuff, as the accounts receivable is climbing and the days in AR is climbing, there's also a lot of things that are going down, 50 to 75% as far as how long we're sitting on claims before they go out. Went from about 4 days down to about 35, 40 minutes.
Will you have that search term,
Yeah, it's in the dashboard, and that's basically where I'm bringing it from, but I'm taking all the way through June to give you those statistics, so. Yeah, just a preview for next month is although some things are going up, there's a lot of hard work doing to bring them down on the other side too, so that we don't sit on them, they go out the door correctly the first time.
Do you have June collections?
Yeah, June collections is actually 3.46 million. So you can see it, total record, it's best month of the year, if not of all, in a long time, so.
Yeah.
I'd say that our staff went after it.
Yeah.
Good job.
An amazing staff.
Do you want to speak to what might have been some of the reasons for that?
Yeah, so we had a number of things that took place in June, definitely. I looked back to, on hand, I had back through 2017, definitely the highest month since the beginning of 2017. Things I think really contributed to that. We certainly had some additional challenges, new positions becoming vacant that previously we had people in. So we certainly had extra challenges, but we underwent the weekly revenue cycle assessment, and I think that even though we hadn't received the feedback from that completely yet, most of the way through the month, I learned a lot from the
who was the
consultants.
assessment from?
Whitley.
Do you recall that we entered into an agreement with our auditor Whitley to provide an assessment that would help for two purposes. Number one, with that coming on new, that would give him a benchmark, an idea of where we stand with snapshot. And it would also, since Susan has indicated that she would wanted to step down from being revenue cycle manager, that we would give the person coming in an idea of where we stand. You recall this? So
So during
that's
that,
what she's talking about.
during that process, I worked very closely with Teresa, was the lady's name, and there were a lot of things that she was able to say, hey, what are you doing here? And then it's like, oh, hey, yep, we need to go look there, we need to do these things. And so as we went through those different conversations, I was able to take that and go and say, okay, we need to redirect some of our attention here versus other places where we, sometimes you have your head down and you can't see the forest for the trees, so to speak. So I was able to kind of assess things and prioritize things a little bit differently in a way we hadn't previously done. Also, we devoted less resources to legacy because of those other decisions that were made, and so some of the few resources I had weren't being thrown at the older legacy AR, and we were able to redirect that into things that were helping our current AR. One of those things that I think really impacted it, and we've been doing it, I think, going on about 4 months now, is our registration audit. So the next day after our service is provided, so tomorrow, we actually audit all of our outpatient admissions. The clinics are auditing theirs separately, but I can speak to the outpatient because that's done in my department. So
That's, we're checking coding, if it's coded correctly.
So we check everything on the registration. We make sure that the patient is their correct name. We make sure that we have all the correct demographic information. The name on their insurance card matches the name we've put in the system. We make sure that there's been an eligibility verification done, and that the insurance coverage that's in the insurance eligibility does reflect what we've entered in the system. And going through that has clearly shown us that we are, over time, being able to reduce our amount of denials and having to resubmit those. I think that's the other reason for, we also saw a decrease in June of our adjustments, because we were able to get things out the door faster. And we're getting paid the first time and not having to resubmit things over and over. That's why a lot of our AR is older AR. We're being able to collect on the front end better, because we're starting to figure out the things that are helping us do that faster. So I really think that those registration audits paid off. In fact, Whitley notes in their report that our outpatient admitters had a less than 3% error rate. And during the last month of May, we had no errors from them in an entire week. So that's pretty substantial considering we went from 75 errors a week when we first started auditing 4 months ago. So really motivated our staff to see that we were taking an interest in giving them the tools and resources to help them improve that. And we're now seeing that return on the other side. Other things that I think were helpful, we've greatly reduced the DNFB, which means we're getting those claims out the door faster. We get the claims out the door faster, we can collect the money faster.
So, explain what that means again.
Discharge, not final bill. So it means the patient's services are over and done with, and we have not sent out their claim for whatever myriad of reasons. There's lots of reasons why that occurs. But we're being able to streamline that process, something not specific to revenue cycle, just our facility as a whole. Being able to drive that number down, which allows us to get our claims out the door. Our standard delay is set at 5 days. So the goal would be that the claims out the door in 5 days. That was not the case for a very long time. So we're moving in the right direction to have the tools available to get us where we all want to be in the revenue cycle. Other things I think attribute, our new space is great. It's very quiet and fewer interruptions. So we loved our roommates, but we are very happy with our quiet space where we can easily, and I'm sure they're happy that we aren't their roommates anymore either. So that's working out well for us. And then I think lastly, I was talking with the team tonight, before 5, we just seen a lot of high swing bed numbers. I mean, I think the last 60 days you had a lot of swing beds, and swing beds bring us more money for Medicare. And so we always, when we have a lot of swing bed patients, we see increased revenue. So I think that is easy. It's not easy, but as you drive down DNFB, then you get the collection faster. So lots of contributing factors, but the team did work extremely hard, and they're all very, very excited. And
So you guys have been in the new building for about a month?
thereabouts. Yeah, I think it was the first part of June. Well, no, I guess we were the last week in May. I think that last week in May. So, yep, we've been there about a month. It's figuring out how to not spend all day driving back and forth was a little bit challenging at first, but now I try and plan things so I only have to come over once a day, plus the staff needs.
Give your team our appreciation.
Thank you, I will.
Thank you. Any other questions? Okay, Ed, you're back on.
Back on, days cash on hand. For me, we had cash on hand 92 days, 3 more than this time in 2020. So it's, I know we went down from the previous month, but we're still, I think, above target of 90. Which is like to be one not out there yet. Monthly net income over here is, for May was 4.3 million gross, minus the 901, minus the expenses of 3.1, and comes out with a surplus of 304K for the month of May. This next one, you can look more at the year to date, because it's just a repeat of the fund. I'll change the slate a little here. But, you know, the revenue for the year 32, expenses at 35, the net operating add back, give or take, is 877K with a net income, or net deficit of 1.7. I think June,
Seems to be digging our way out though.
yes, absolutely, I think June will be a start. That being said, it is a battleship, you know, it takes a while to turn. For the balance sheet, not a big difference between May and April. You'll see, you know, some of these things just move into different buckets theoretically. I think overall there was about a $245,000 change month over month. So total assets at 58.9 million, total liabilities and fund balance at 58.9, so 10.54 is that. The fund balance plus that current income of 385. That's all I have for the hospital.
Okay, any questions? Okay, you're still up and that's with Who's Like Medical Services.
Awesome. All right, Lakeview Gardens. Not much change month over month. You'll see it too, the difference of 251 in long-term care and the 30 to 36, so one moved over from one patient, probably moved from one to the other. Relatively flat. The biggest difference between these is the expenses, and there's about a 29 to 39 right here, the 60, 89 for the contract labor. And then $1 million for the year, you know, that's the budget buster, honestly, and it's something I think that's being addressed with the CNA scholarship program. And I think we'll see a significant decrease in the near future. But overall for May, it was a deficit of 148, and for the year 1.6. On a positive note, we have the Lake Health Medical Supply. Its revenue went up about $2,800 from 39 to 42, 355 for the year. What you're not seeing here, and you'll see is the medical supplies. It's not footed in here, going from 63 to 698.
Would that be your cost of goods sold?
Yes, on this it will, yes.
Some doesn't.
Right, and then it might be the way that, maybe that's, for this, it'd be better if we put it up here.
But the significant difference, you know, cost of sold is 698.
Right.
47,000 sales doesn't.
Yeah, it doesn't work, right? And that's the thing is we have to go back and
Something's in the wrong bucket.
right, correct. The other, I guess, contributing factors to this, and what you'll see more of in June, is the recall of the CPAP machines and stuff, and the return of all those Philips machines. And we switched them out for ResMed.
I assume in a recall, they offset some of our incremental costs of doing it.
Not yet.
Not yet.
It's a national deal. It's a big deal. And we had patient care to deal with more than anything else.
Well, I agree, usually in manufacturing, it's their fault, and that's something they will eventually should take care of.
Eventually,
Should and would are two different things.
Go through checking.
So overall, the May net income was 18,465. Like I said, it's a little skewed. And for the year, they're positive for the year, 2255. I think everything will probably normalize in June. And that's all I have for Lake Health and Medical Supply.
Questions? Nope. Okay. Takes care of that. Okay. EMS service update. Tyson, you're up.
Perfect.
We're glad to have you on board.
Thank you. Thank you. The biggest thing I can think of right now as far as the service update, things are going well. We are starting to see more ground transfers versus flying patients out, which I think is a great thing for the community. Most flights are about $60,000 to go to Medford, and we take them by ground, it's like $4,500 in game for the consumer.
Are they mostly Medford and Bend?
Primarily, we've done Bend. We ended up taking one to Ashland, I think, since I've started. And I've even done a return trip from Sky Lakes over to Cedarville for a gentleman that was getting discharged from Sky Lakes to go basically to the nursing home there in Cedarville. He was getting towards the end of his days. And, we are getting, and I've worked with Susan on, we do have the ABN form that we need to start using for such transfers. We're getting a contract in place with AirLink for, I guess in the past we have been doing, they've considered that a service of the hospital when we go pick them up at the airport and bring them over. And we haven't been billing it, we've been just chalking it up to community benefit. Problem with that is, since the first of the year, we've had 34 instances where we've had 2 or more ambulance calls at the same time. 17 of those have been due to flights. So by getting a contract in place with AirLink, we'll bill them directly. We can operate with our variants, and I only have to provide the ambulance and a driver instead of taking my whole crew out.
This is to go out here to the airport?
To go out to the airport, pick them up, and bring them over. I know with winter months when they're trying to hit their weather windows, we will end up just taking the crew or finding a crew to take the patient from here over there. They land and move the patient. But I think that'll be a huge benefit. Met with Commissioner Williams yesterday. We're going to have a meeting up at Summer Lake Lodge middle of July to finalize the county ASA plan, the ambulance service area plan. It hasn't been updated since 1996. And it's supposed to be gone through and updated every 5 years per the state standard.
We just waited a century.
Yeah. You know, we let it slide. We let it slip under the radar for a few rounds. And then on top of that, looking at, I just found out today, the boundary that Humboldt County uses, or Humboldt General Hospital for their EMS and rescue, comes about halfway to Adel from Denio. And so that has been, we were trying to figure out our boundaries. I reached out to them to try to figure out exactly where our boundary is and where theirs is. Because they're even going up almost all the way to Fields as well, tonight. And so I think it just depends on which dispatch center gets the call, whether we go or the Warner Valley crew goes, or they come up out of, I think they have a station.
is that Winnemucca?
Yeah, they have a substation 40 miles north of Winnemucca, but
In Nevada or in?
in Nevada. So I reached out to their EMS chief today and haven't heard back from him yet. So hopefully we'll get some clarity there. I'm not entirely looking forward to a trip to Denio, but I know it comes with the territory. We had a very successful drill over the weekend. The hospital had a grant that brought in a company that was kind of a joint venture, EMS and ER, for an extrication scenario. Got some pretty good feedback out of that. Crews did well. There's definitely some learning curves that we need to get worked through, and it's primarily stuff that, you know, this is the way we've always done it. But now we have a mutual aid agreement with Thomas Creek West Side for anywhere that our ambulance responds, they will come assist with vehicle extrication. And I guess traditionally they haven't done that. Meeting with Daniel Tag, I was like, primarily we have the equipment, I just need manpower. He goes, well, when I talked to our board about it, I told them, they go, well, so our ladder truck with our rescue tools could end up at the top of Doherty Slide. He goes, yep. And they said, okay, and signed the mutual aid agreement. So they look at that on the return end, because then they can put a new driver in the driver's seat to drive the engine or ladder truck back to the station and get some driving training in. So it's kind of a win-win for both of us. And what
Would
else?
they want to run a ladder truck out to?
Oh, they will. Yeah. I was shocked. I told Daniel, I said, just stick some personnel in your Tahoe and send them out. That's all I really need is more manpower. And he goes, no, we'll bring the ladder truck. Okay, I wouldn't do that, but it's fire district, so.
Where are you with staffing, Tyson?
Just added, I have one open full-time EMT position, filled one, so now we have 3 full-time EMTs on shift. That makes it much easier for me to facilitate transfers, because then I don't have to, and we have a variance, so I can just find a driver to take one of my EMTs or my paramedic, depending on the level of service needed, to make those transfers happen. Still have one open paramedic position. The crews are really wanting to switch to a 24-hour schedule similar to Burns and most fire departments, the way they work, instead of the 12-hour shift which they do now with the on-call stuff at night. They're going to be here so they can get out the door in a couple minutes.
Also, we're running a 12-hour.
We're running a 12-hour day shift, and then at night they're on call, and most of them either stay at the station so they're here anyways, or there's a couple of them that live within a few blocks of the hospital that go home at night. But they're really wanting to switch to the 24-hour schedule, kind of to maintain that work-life balance a little easier for them. And I totally understand that. It's just trying to recruit another paramedic to come into Lake County. The one application I did have, the guy wasn't willing to relocate, so not exactly an ideal candidate.
Right.
Um,
What about equipment-wise? Are your vehicles, equipment-wise, vehicles are where we need to be?
Yes, I think we have it in the budget to buy a new one. I was supposed to have a quote by now, but I guess it's coming tomorrow. I kind of prod the guy a little bit to spec out an ambulance that's gonna be more user-friendly instead of the demo that we do have. And then Charlie and I discussed making a 5-year rotation. Is that what we talked about Monday?
So
For the replacement plan?
I think one of the things that we want to make sure the board understands is that in our lease agreement with the disaster unit, we have effectively 3 options. One is to continue the lease option, where we're leasing the equipment and supplying it to maintain it. Number 2, get a fair market value and either opt to buy it from them, or 3, elect not to continue with our lease agreement and acquire other equipment. So those are our principal options. Tyson and I have talked about getting fair market value assessments on the instruments as they are now.
Yes, the first out ambulance we own, and it's great. The one that we use primarily for ground transfers is a 2016 that's leased from the disaster unit. And it even could be with a little stuff moving around, we could put extrication equipment on it. It's a simple thing of moving the shelf and putting in some brackets. It wouldn't take much to outfit that with some extrication equipment, so I think that one would be beneficial to buy from the disaster unit at fair market value. The other 2, one of them is 96 International. The other one's the 2000 International. Both of them are getting towards, they look great. They did a great job taking care of them as far as appearance goes. They still function, but I guess over the weekend, neither one of them, even though I just had the AC recharged at maxes, neither one of them really blew cold air, and it was really hot in those patient compartments, which violates state standard. The 96 we use as the reserve over here the other one's out in Adele. The 96, I'd have to double check, but I'm not sure unless we can get some sort of variance. I believe it will not be able to be licensed the next go around because it'll be 25 years old. So it'll be past its service life, basically. I believe the other one is the one that has more issues with the, one of them doesn't drive really well, it's all over the road, and one of them doesn't have air conditioning or a heater that constantly blows in front, so my drivers are hanging their head out the window to try to cool off when they're going down the road. Chuck says it works just fine. He doesn't mind it being out there in Adele, so that keeps him happy for another year for me to extend that lease out. That's fine. But eventually, I've told him, I said both of those, as we start acquiring newer ambulances, both of those are on the chopping block, and you guys are gonna have to figure out what the disaster wants to do with them. As you still own them. So that's kind of the big things I got going right now is, like I said, the ASA agreement getting finalized because we think we have till August 16th to get that on file with the state. And our lease, I think we let Charlie know by the end of the month whether or not we're gonna pursue renewing the lease or go for the fair market value. And I think the fair market value option is probably the better option.
Good. Welcome.
Thank you.
Yes, welcome to Lakeview.
Thank you.
Do you see any other kinds of service that we ought to consider differently or equivalent, or something that you'd like the board to be thinking about?
Not that I can really think of it at this point. I mean, everything's still, I know there's definitely a need for a lot more training with our full-time staff, and most of them have been just single role paramedics, not coming from a fire background or anything like that. So running extrication equipment is kind of a new thing for them. But I do have that on the agenda, the 23rd and 24th. The guy from Almatro Tools, he's a little bit Newburgh fireman, which has now been absorbed by Tualatin Valley. But I've had a couple classes from him. He's coming down to put a class on for us. Kind of self-serving for him because he knows we went out for a grant to try to buy new extrication equipment. So now he's going to come down and show off all of his tools at the same time. But that works. The only other real thing I think, and I've been working with Ed on this as far as our ambulances go, is outfitting them with the auto load capabilities for our gurneys. They're about a 20 to 25,000, I believe. Add on to the ambulances, but it does the lifts for us, which I think in the long run, considering the staffing that I do have over there, I think as far as everybody over there goes, I'm bongo. I can do the heavy lifting. Most of them have to use 2 people to lift the gurney, but it will save us.
We're seeing heavier patients too, aren't we?
We are seeing some heavier patients. And those things, when it comes down to it, they're worth their weight in gold as far as paying for themselves. They save one back injury, they're worth it.
How many do you currently have?
Zero.
Not the rotary coat for the purchase of.
Probably a power gurney. We do have power gurneys.
Yeah, that's what I said.
This is a loading system for those.
Yeah.
And actually, I reached out to a friend of mine that works at Climate District 1, and I haven't quite got the head on this one. I'm waiting for him to give me some verbiage that they outfitted all of their ambulances with those auto loaders and bought the Lucas CPR device for each ambulance with COVID money.
Really? How did they do that?
Well, if the COVID patient goes into cardiac arrest, you need a Lucas.
Lucas, if you recall, was the unit that Troy brought and showed everyone how that provides the compressions. Which
Already
is,
saved one life.
Within like the first month, didn't it? I believe it was. Within the first month that we had.
So the COVID money would be very interesting if we pursue it that way.
it's a very good thing to know.
I asked him how he did that, and then I like to utilize my, because I come from a fire background, so I have contacts throughout the state as far as different departments. And one of my neighboring districts where I came from was Lower Oklahoma ambulance, which is a hospital-based ambulance just like us. So I reach out to those guys as far as, hey, how are you guys doing things? I didn't know it until I started here, but a guy that I was a student with actually works up in Burns at Harney District, EMS. So I've got a contact up there. I'm trying to recruit him to come down here, it's not working really well. But I like to bounce ideas off of them and see how they're doing things. Klamath District 1 runs single role paramedics. Our guys are paid just about the same as those guys are. The only difference is they don't get the first retirement here, so it is what it is. But they are, when it comes time for verbiage or something like that, when it comes to COVID money, I have no problems making a phone call and figuring out what other folks are doing with it.
Excellent. Good. Thank you.
You bet.
Any other questions? Hearing none, moving on. Medical staff privileging, Dr. Foster's not here.
Before we do that, we have patient safety.
Oh, I'm looking at the one you said. Okay,
Sorry.
that's okay. Oregon Patient Safety Commission, that would be Mr. Twig.
So I think Jen sent out to you a copy of the hospital participation agreement with the Oregon Patient Safety Commission that encourages us to participate in reporting of serious adverse events. They have written policies and procedures on safety activities. Did everyone get a copy, a chance to review this?
I did not.
I didn't either.
Okay.
It came in a second email after the first one came out last week. So, sorry. I think yesterday maybe. You want copies?
So
Do you want copies of it or?
I can run make copies for you.
I have two right here.
I'll take one and make additional.
Thank you. So sorry for that. If you'd rather than approve this, something you haven't read, it's not overly complex, but it's essentially saying that we will participate in this Oregon Patient Safety Commission, providing reported information.
What is the benefit for us, Charlie?
We can use our data and compare it from a benchmark standpoint to other hospitals. And so we can participate in that process. We have to report so much, it's silly not to report this kind of.
It's not an additional workload.
It is, but it's not a huge amount because we're tracking the information.
Is this an Oregon sponsored program or HSU or?
No, it's the Oregon Patient Safety Commission. It's not part of the Oregon Health Authority, but it's defined in law that we have to do something to this effect. So it's not exactly a completely voluntary, we just have to.
Does there,
Makes sense.
It does.
is there any disadvantage?
We're all focusing on patient safety. When we think about patient safety, some of that is, do we drop somebody when we're lifting? Do we harm one of our employees? Are we making sure that we're giving all the correct medication? Are we, all the normal areas where patient harm could occur? We're focusing on it. And so we want to track it and make sure that we are saying,
We're pretty much already tracking all of that.
we're doing it. So it's just essentially you adopting policy that we would continue reporting to the commission.
More motion or just?
It does require signature by the board of directors. And that's why we would bring it to, we're bringing it to the board. And I'm sorry that you didn't get a chance to see it. We can bring this up after you've had a chance.
Okay. Now we can revisit that a little bit later when we have a chance to look at it.
Doctor, should you
Okay, now we're on to Dr. Foster.
Dr. Foster is in the emergency room, so I'm sure he's got something going on there.
Hopefully he's not a patient.
No, he's the doctor. Correct.
Okay.
So I think we sent out the information to you. If not, this is for the appointment by the medical staff for Dr. Jeffrey Chen, who's the interns. Now practicing, he's here 2 weeks on, 2 weeks off. Been coming, I think it's been about 3 or 4 times that he's actually been. Medical staff approved his application and they recommended the board approve his appointment to the hospital and his privileges as requested.
Any questions?
So move that we accept.
I'll second that.
Okay, been moved and seconded that we accept the medical staff privileging of Dr. Chen as presented. All those in favor?
Aye.
Passes unanimously. Okay, Teresa, you're up.
Oh, okay. I just have one little quick thing that's kind of interesting. We did receive a letter a couple days ago notifying us as a facility that the Klamath Community College nursing program is going to be approaching the State Board of Nursing to start an LPN program. So hopefully within the next year, that will be approved. She's fairly confident. And so we can start seeing LPNs come into the workplace, which would greatly benefit the long-term cares and doctors' offices. Occasionally, we use them in acute. So
Teresa, just for the audience, LPN stands for?
licensed practical nurse. Thanks. So that program usually is like a 12-month program, so they can certainly turn those out more quickly than RNs, and there's very few LPN programs left in Oregon, so this will be a really great benefit, I think, to healthcare in our area. So I just wanted to share that with you. Another great thing that Allison is doing with the KCC nursing program.
Would they be able to do that from Lakeview, or do they have to go to Klamath?
She hasn't, I don't think she's to that point yet, but I can't imagine that it wouldn't be a possibility. Because I'm having to write a letter of support and let the state board know that we have the ability to allow clinical experiences or practicums to occur for those students here at Lake District Hospital. So, should be a good thing.
Any other tidbits for us?
No other tidbits that I can think of. Any questions from me or concerns?
Thank you.
You're very welcome.
Mr. Twait, the CEO report.
Okay. If you have had a chance to look at this participation agreement, just briefly, you'll see that we're following the OARs with the Oregon Administrative Rules. Designated manager for that position.
Lots of OARs.
Yes.
What is the annual fee?
We pay a lot to the state no matter what we do, so I'm not sure there's a set fee for participation in this.
It's the second paragraph on the second page.
They say there's a fee, I just don't know that. But we don't have much choice.
Well, I so move that we agree to participate in the hospital participation agreement with the Oregon Education Safety Commission.
Second.
Okay, we moved and seconded to go with the Oregon Patient Hospital Participation Agreement. All those in favor?
Question first.
Oh, question?
If we join in, I assume it'd be beneficial, but sometimes we could get out of the agreement if we so deep.
The agreement may be terminated by the hospital which participates on a written notice delivered to the commission.
Okay. All those in favor? Aye. Passes unanimous.
Okay. So we have a couple things to talk about in terms of what's not only been going on, but what's going to be going on. So I believe, I hope you have received the evaluation forms for both self-evaluation, evaluation of me, and some comments. But we're asking that you do is complete this, send it to Jen. I originally thought it would be best to send it to Paul McGinnis, and he said, no, send it to Jen. She'll collate it and give it to Paul. So that on our July 20 strategic planning meeting, we'll be able to talk about the results of that. So if you'll grab those surveys and think about them, and think about not only as you're evaluating us, yourselves as well as me, think about what we can do to improve. So that'll be really helpful, and we'll discuss that.
Jen, I think I saw it, the 12th of July is when you'd like to have those by.
Yes.
So that's correct, that's 5 to 12, so that would be really helpful. We have an agenda that we're working on. Anyone has any individual items that you think we ought to bring up, don't hesitate to send it to either Don or to me, so we can, as we're working on our agenda.
We have a broad outline already, and if you have issues or, items you want to bring up, let us know.
Next, after talking with Ed and talking with Whitley, I don't know if anybody wants to see the Whitley report, or is that too much in the weeds for you? If you do, we can send it.
Is it a financial report already?
No, this is an evaluation of our revenue cycle process. This is what Susan was talking about in terms of how just the conversation with the Whitley expert that was here, Teresa Jones. This is her compilation of findings and suggestions.
I'd like to see it.
Okay, we'll get a copy of it. Anybody else? I didn't want to know if you wanted to get into the weeds that much, but happy to provide you that information. So we'll get that to you. And they had some suggestions. One of the things that they're going to be doing is doing the work on our CPSI claims following. It's been a little bit, as Susan said, bumpy as they've taken on that, but it's still in process. Is that essentially correct? So one of the other suggestions that we had was that we consider looking at, during this next at least 6 months, transition from Ed being here new. Remember, the purpose of our survey was to provide tools for both Ed and for our new revenue cycle manager, areas that they can focus on, but also to look at ways that, since we've been using Cerner for a year now, how can we do a better job? And that did help us do that. In the process, it was recommended that we consider outsourcing some of our collection for at least 6 months. Whitley offered their services. Ed suggested we think about a company called HRG, Health Care Resource Group. It's a company that does this a lot for a lot of different hospitals. We looked at the contract. We reviewed it a little bit in our finance committee meeting this week, and the suggestion was that we go ahead and do this. So I signed the contract, and Ed will be meeting with their team, with Susan.
Just for a 6-month period, we can review it.
But this is a 6-month agreement. Now, the purpose are, keep in mind, our replacement revenue cycle manager will start in July, thereabouts. And it'll give that person time for training. We've had a fair amount of turnover. Susan and her team have done great, but we're down, 4 people? 4 or 5?
Yeah, I had 3 openings and now we'll increase that, so yeah, I mean, we're down to basically 5 FTE to build 23 departments. So that in perspective of what.
And what we also have had is many of the builders are new. So this gives us some breathing room, it's expensive, but it gives us breathing room to get training going, to get some systems up and running. And then depending on, we'll reassess.
What does expensive mean?
Runs between $120,000 and $150,000 in terms of percentage of the cost of the collected dollars. The important part though is we're very good at collecting. We do this a lot. So if we fail to do something like this, what it ends up doing is we forego the possibility of a fair amount of revenue. And we don't want to be in that position. So that's why I went ahead and took Ed's advice and signed this contract. So what do you know about that? This is the first day of our new fiscal year. So we do an inventory. And that inventory finished yesterday. And to put it into perspective, we have an inventory value of $224,000, 1,130 items. We were off by $56.50.
We're taking that for yourself.
You know, that kind of quality, I would say I pay. Because that's, you know, it's extraordinary.
That was a plus off, not a negative.
Oh, well, then, that means I take it back.
Okay. Now, this is not a one-off. Last year, they were $84.46 off. So they're consistently getting better. But, you know, they can't even get the 99.97% accuracy. It's extraordinary. So we have some really good, strong teams, whether it's revenue cycle, or it's in supply chain, or in nursing, a lot of really good services that people do.
Does that inventory include the pharmacy?
It did not include the pharmacy. The pharmacy inventory is separate.
Right.
Remember, the pharmacy is actually a contract service. And it is contracted with a company called Amerisource Bergen Corporation. And they'll do their inventory the end of August. So effectively August 15th. So they're just two separate different. I told you a little bit, or we talked a little bit about the CNA class that's underway. Teresa, do we have 12 or 10 in the class? Do you know?
7.
7. We have 7 in the class. So not quite as many as we have.
We started with about 15, but they're really good candidates, they're doing well. So, you know, 7 is better than the 2 we had in the last class. Very excited about that. Our clinical nurse educator, Terry Carlin, has now started in her job, and she will be doing the clinicals with those students on acute. And for the next CNA class, she will be doing the entire program here under the umbrella of KCC. So that's going to decrease the costs that we have to pay KCC, and I think it's really great for us to keep doing the classes.
So thank you for that. Next thing I want to talk a little bit about is our grant program. I've been trying to provide you with grant updates every so often. But I think to put it into perspective, about 5 years ago when we hired Christy Alvarez, we were getting just almost no grants. We now have easily a dozen that we are receiving, and they're on all different kinds of things. Several are from Eastern Oregon CCO, but we have others like the program that Tyson talked about, the training program. That training was worth $10,000. It was a lot of money. But what's even more astounding, we got a grant to talk about housing. Housing is a big issue throughout Oregon, and it is especially a big issue in rural Oregon. The county is no not unique to the rest of the state. So we got a grant from the Myers Memorial Trust for about $185,000 over a couple of years to try and do some assessment on housing needs and what we could do to try and address some of that. We explored the opportunity of having what's called supportive housing for people that have trouble with being consistently in homes. And doing supportive housing includes having mental health services provided to people in that environment. It was controversial about a year ago, location being where the Lakeview Flockers is. Well, I learned today that the Oregon Health, it's called the Oregon Housing Association, Oregon Housing, wrong.
Authority?
It's like the Oregon Housing Authority. Awarded that project $4.2 million to build a 17 unit housing facility.
How much?
$4.2 million. And that will go toward purchasing the property, building the facility, and then all the arrangements to go through that. There is a contractor, there's an architect, all of that is part of this grant. So it's a very big grant and first step toward the supportive housing in our community.
So we would be expected to help provide medical services to that facility.
What we would do is provide mental health services. And the Oregon Housing Authority would be handling the management of that, and they would be providing they would do it's not our project, but we would provide the mental health services. There's additional grant funds that we have through that to look at other kinds of housing needs, whether it is to evaluate high-end housing, low, middle housing needs, all that. So,
Is this at the same location, same concept as a year ago?
I believe so, yes.
We're talking $247,000 a unit.
This is money coming from the Oregon Housing.
That doesn't matter, I mean, it's somebody's money.
I didn't award the grant. I didn't even just tell you what they do. Right. Okay. We'll have more information on that as we go. Well, it's not as critical for you. I think it's important to understand what we offer for our employees for their pension plan. So we sponsor, and we have a percentage of all employees' income into a 403B plan. And then employees have an opportunity to put money of their own into that plan. It's now in excess of $15 billion. It's been in effect for 15 years, I believe. And the fees, we were able to reduce them significantly in the last go around. You may know Walt Davis as one of the agents for Edward Jones. Their firm he is actively trying to find opportunities for our employees to work to support their retirement plan savings. So I think it's our obligation as an organization to provide get the lowest fee possible for the best service for all employees. And charge Walt with getting every single employee to save some of their own money, not just money that the hospital puts in. And so he is actively working that. And I think that's an important thing for people as they plan their retirement, and not just Social Security. So it's astounding to me to see how much money that is now going It's a lot of money. Happy to provide information about that. Two other things. I read this afternoon that the state of Oregon, since all know that as of yesterday, the governor opened up the masking requirements. We're still required to mask in the healthcare entity, but if I wear my mask, you can't hear me, so that's why I'm not wearing the mask. As of this afternoon, we were 5,119 people shy of getting vaccinated to hit the 70% governor. Unfortunately, for Lake County, we're at 35%, not 7%. So we need about 2,100 more people to get vaccinated. To try and address that, the state and the federal government has given us another big tranche of monies. It's about 300, and we get all the money, it'll be about $370,000 to be used to try and encourage people to get vaccinated, as well as to talk about COVID mitigation. Some of that means how do we help people stay safe. We'll be looking at ways to give incentives to people of all different groups to get vaccinated, and you'll start seeing some of that in Lake County, specifically for Lake County. And we'll look at the prospect of acquiring some means of providing vaccinations in other parts of the county. We drive it around, or how we do that, we're still looking into that. And of course, if we get this money and we don't spend it, we have to give it back. So we'll try to be as prudent as we can. Last thing, Dr. McGillicuddy, who's been our orthopedic surgeon, has tendered his resignation. He'll leave in about 2 months. It was just too hard on his family to be as far away. So we're now working on other alternatives. You may recall Mary Skrinsky was here for a little while, and about a year and a half, and that too was difficult. It's hard to do. And we'll continue to pursue it. Do you have any questions on any issue I can talk about?
Back on the urban housing, was that urban housing authority or urban housing and community services?
Is it climate housing authority?
It's being handled through Klamath, the Housing Authority. But the actual funding came out of the Oregon, I'm not sure it's the Oregon Housing Coalition. I have the exact name, I just didn't write it down. That concludes my comments. If anyone has any questions?
Any other comments, questions? We'll,
Well, I guess I could say one thing still in public session. The Teamsters Union is voting and hope to have a decision by their membership of the negotiated agreement by July 15th. I was not able to bring it to the board tonight for approval or ratification. So it will be the August meeting. So I will be able to give you the terms of the agreement if the membership approves it. They have yet to not approve what is negotiated. And since I've been here, Teresa, have you ever, in your recollection, they've always approved it. So I would say it's virtually done, but until it's not done, I can't explain.
okay, thank you. We'll adjourn into executive session under ORS 192-60, record A personnel, record C medical staff, E real estate, and H I will take a 7 minute
Or I can
break.
just take it a minute.
Well, these are the
Okay.
I need them to go out.
The old lady didn't
That's how we do it.
Yeah, you know.